Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.
Hello once again. Good morning and a very warm welcome to our CATHIP Health Hour session today. It's an absolute pleasure to have everyone here this morning, and we really appreciate your time joining us for this session. My name is Dr. Diana Asante, a GP in Stafford. I'll be your host for today. So we would be having another interesting session today. Now, through the month of May, we've focused on different topics in relation to diabetes. We've talked about diabetes and the link with other conditions. We've talked about lifestyle conditions that can help us improve our diabetes. And today we have another interesting strand that we're going to be discussing. So obviously we are on Zoom today, but we're also live on Facebook, on YouTube as well. We have a very experienced consultant in the area of diabetes today to talk us through our topic, which is gestational diabetes and type 2 diabetes in children. We're going to learn a lot about how people having diabetes in pregnancy can have after effects or even increase the risk later on. So it is my singular honor to introduce to you a consultant in diabetes and endocrinology who has a specialist interest or a subspecialty in diabetes in pregnancy. And she is a consultant in Wakefield. Her name is Dr. Tolulope Shonibare. Dr. Shonibare, over to you, and it's an absolute pleasure to have you today. Thank you so much.
Thank you. Thanks for inviting me back. So what I'm hoping to do today is cover Thank you for having me. What I'm hoping to cover today is gestational diabetes, the risk to the mum and the long-term risk, the short-term risk to both the mum and the baby. Can we have the slides if that's okay? Okay, so next slide. So we're hoping to cover gestational diabetes, what it means and how it's diagnosed, and what the risk factors are. And then we'll talk about the short and long-term risk to both the mother and the child, as I mentioned before, and how we can manage the condition and also reduce the risk for the future. And this is a disclaimer, I'm not a pediatrician, but I'll briefly talk about type 2 diabetes in children. And I'll also talk about a landmark study called the HAPO study, which is where all this evidence is coming from. Okay, next slide, please. So what is gestational diabetes? Essentially, it's when a woman who doesn't have diabetes or prior history of type 2 diabetes develops a high glucose in pregnancy. And essentially what this means is that it's like a temporary form of diabetes where the glucose readings are raised throughout the pregnancy. However, as soon as the baby is born, the diabetes disappears. It affects 1 in 6 pregnancies worldwide. And in Asian populations, it affects roughly 1 in 4. Unfortunately, we don't have any data for how many, how much it affects Black pregnancies. What we do know about gestational diabetes is that the incidence is increasing worldwide, and this is mainly due to risk factors from the mother. Next slide, please. So why does gestational diabetes happen? This tends to happen for 2 reasons. So the first reason is insulin resistance. So when a woman is pregnant, she has lots of hormones swimming around, because especially from the placenta. So you've got estrogen, you've got cholesterol, you've got estrogen, you've got progesterone, and you've got cortisol. And what happens is all of these other hormones start competing with insulin, and that makes the insulin less effective or less efficient. And another reason why women develop gestational diabetes is that the insulin that the mother's producing is not enough to cover both her and the baby. So the insulin levels are not sufficient for the whole for the pregnancy. And there's also genetic factors which contribute to why women develop gestational diabetes. Next slide, please. So if you became pregnant and you attended your antenatal clinic appointments, there will be certain risk factors which they would screen for. And if you identified as having any of these risk factors, then you would be screened for gestational diabetes. And these risk factors include a raised body mass index, or obesity. So if you had a body mass index of greater than 30, then you would be classed as having a high risk for developing gestational diabetes. Also ethnicity. So if you look at both the populations in England, sub-Saharan Africa and America, Black people, Hispanics, Asians tend to have a higher prevalence, and also people from the Middle East tend to have a higher prevalence of gestational diabetes. So if you were from these if you were from any of these ethnic backgrounds, then you would be classed as having a high risk. Also, if there's a family history as well, so if you have a first-degree relative that's got diabetes, so either your mother, your father, or a sibling, then you would be classed as having a high risk. If you've previously had a big baby, so if you were told by the midwife that your baby was big, especially weighing greater than 4.5 kilos, then you would be marked down as having a high risk for gestational diabetes. If you'd had gestational diabetes in a previous pregnancy, then you are at risk of having gestational diabetes in the next pregnancy. And also maternal age. So anyone above the age of 35 these days would be screened for gestational diabetes. Next slide, please. So in terms of how to diagnose gestational diabetes, we usually use something called an oral glucose tolerance test. And essentially, this is a glucose drink, and it's 75 grams of sugar, which is, 75 grams of glucose drink, which you're given. Typically, you would be offered this test between the weeks of 24 to 28 weeks. If you'd had gestational diabetes in your previous pregnancy, then you would be offered this test a bit earlier at 16 weeks, and then you'll have the test again at 24 to 28 weeks. Essentially, your blood glucose is measured at the start before you take the drink. And after you've had the drink, they'll measure your blood glucose again 2 hours later. And what they're looking for is a rise in your blood glucose. As I mentioned before, gestational diabetes is when a woman is unable to maintain her glucose readings within the normal levels. So if your fasting reading is high, so you haven't had anything, so before you attend the test, you shouldn't eat anything in the morning, you shouldn't have breakfast. So when you attend the test, you have the glucose drink. If your fasting reading is 5.6 or greater, then you would be classed as having gestational diabetes. And after they checked your blood glucose as 7.8, if it's higher than 7.8, then you'd be classed as having gestational diabetes. And one thing I'd like to stress is that some people feel that you have to have both the fasting and the 2-hour for you to be diagnosed, but it's either if your fasting is high, but your 2-hour glucose is normal, you still have gestational, you will still be diagnosed with gestational diabetes. If your if your fasting was normal and the 2 hours high, then you will be classed as having gestational diabetes. Next slide, please. So what are the symptoms of gestational diabetes? Essentially, it's most people don't have symptoms. Although so most people don't have symptoms because the glucose readings are higher than usual, but they're not as high as someone who has full-blown diabetes. Sometimes we can find that women who present late in the pregnancies, we notice that, for instance, the baby starts to grow big after quite a long period, and after a certain gestation and pregnancy. So after 30 weeks, the baby starts to grow very quick, and then at that point we would suspect that the woman might have gestational diabetes. Also, if the abdominal circumference, so the baby's stomach starts to grow very big, because I'm sure most of you who've had babies, when they're checking your baby would have growth charts. So they look at the size of the baby's legs, the size of the baby's head, the size of the baby's abdomen. And typically what happens is that if we notice that the baby's abdomen is growing a bit too big, then we would suspect that the mum might have gestational diabetes. And then there's something called polyhydramnios. So if there is excessive amniotic fluid around the baby's abdomen, also if it's excessive amniotic fluid in the mother's womb, then we might suspect that the mother might have gestational diabetes. Next slide, please. So in terms of how to manage gestational diabetes, the first thing is glucose monitoring. So if you were diagnosed as having gestational diabetes, you would be given a glucose meter, and that's to monitor your glucose readings before you eat anything in the morning, and then 1 to 2 hours after you've had a meal. And what we're aiming for is a fasting reading of 5.3, and then a 1 hour reading after you've had your meal of 7.8. Most of the time, when you have been diagnosed with gestational diabetes, you will be referred to a dietitian, and the dietitian will give you some tips on the foods to eat, foods to avoid, and also foods that can cause your blood glucose readings to rise very quickly. For some women, diet alone, just a change in diet, is enough to manage the gestational diabetes. For some others, diet isn't enough, and they have to go on to the next step of management, which is metformin. So metformin is a drug which has been around for many years. We use it for patients who have type 2 diabetes, but it's also safe in gestational diabetes, and we've used it quite regularly for women who are unable to manage the blood glucose with diet alone. If metformin and diet is not enough, then we'll go to the next step, which is insulin. Quite often, again, this is temporary. So quite often what will happen is we'll give you insulin either as a background insulin, so a long-acting insulin, which you take towards nighttime before you go to bed. And that will just manage your blood glucose readings overnight, and then throughout the early hours of the morning. Sometimes we can have to give you a short-acting insulin for when you have a meal, because people have a spike in the blood glucose after they've had a meal. So we'll give you a short-acting insulin. If you're diagnosed as having gestational diabetes, you will have regular scans of the baby, and you would have, these are growth scans which you have at 28 weeks, 32 weeks, 36 weeks, and 38 weeks. Sometimes in patients who have gestational diabetes, the obstetricians might decide to deliver the baby early for many reasons. So if the baby is growing too big and too quickly, or if there's any other adverse signs, or sometimes if the baby isn't growing well enough, or if there's any other adverse signs, then they would advise that the baby's born slightly earlier. As soon as the baby is delivered, all the treatment goes away. So as soon as you've delivered the baby, you stop taking your insulin and you stop taking your metformin if you were started on it. Next slide, please. So gestational diabetes, I think some people might argue that if I have gestational diabetes and I deliver the baby and the diabetes goes away, then what's the big deal? Why do we have to worry? It's a temporary form of diabetes. I've had my baby. Why should I worry? Next slide, please. Actually, gestational diabetes is very much a big deal. And there was a landmark study called the HAPO study, which essentially was done between 2000 and 2006, but then there was follow-up studies. And what they found was that women who didn't have type 2 diabetes, so women who didn't have type 2 diabetes, there were some women in between who didn't quite have a normal sugar level, but then they had sugar levels that were higher than normal. And essentially, this was quite a large study where it was carried out in many countries, and there was many people from different ethnic backgrounds who participated in the study. And essentially, they identified these women who didn't have diabetes and but had a high glucose reading. And the question was, what do we do about these ladies? Are these ladies a risk? Because we already know that anyone who's got type 2 diabetes is a risk of many metabolic problems. So the question is, if these women, who are in between, have gestational diabetes, is this just, something that we shouldn't worry about? But actually, in this study, what they were able to find out was that, they were able to identify these women and be able to, because around the world, people couldn't quite agree how to diagnose these patients. So in this study, they were able to come up with criteria how to diagnose patients with gestational diabetes. And then what they found is that actually women who had gestational diabetes, similar to type 2 diabetes patients, also had risks within their pregnancy. And then they followed these women up and they found that actually they had certain risks which carried on even after the pregnancy. And then there were some follow-up studies of the children of these women who had gestational diabetes. And they found and there were certain things which they found which was quite surprising actually. And they were able to establish the link between gestational diabetes and long-term health risk in both the mother and the baby. Next slide, please. So in terms of the short-term risk to the mother, so if a woman has gestational diabetes during the pregnancy, she has a high risk of developing preeclampsia. She also has a high risk of developing preeclampsia. Essentially, is a metabolic disorder where the blood pressure is high. And sometimes the blood pressure is high, and if it's not well controlled, it can lead to seizures. Sometimes they leak a lot of protein in their urine, and it's quite a serious condition. And sometimes, women who have gestational diabetes, they're a high risk of having a high blood pressure. They're a high risk of gaining weight, and they're more likely to be induced and more likely to have a cesarean delivery. Next slide, please. So in terms of the long-term risks of gestational diabetes to the mother, so women who have gestational diabetes have are seven times more likely to develop type 2 diabetes. And this is especially within the first decade of after having their first baby, but this is within the first decade of after having been diagnosed with gestational diabetes. And if we go back to the HAPO study, what they found is that actually these women aren't just a risk of having full-blown diabetes in the future, they also have a risk of having heart disease, chronic blood pressure problems, and kidney problems, and raised cholesterol. And women who usually these problems tend to happen when people are over the age of 50. But what they found is that actually these women who've had gestational diabetes tend to manifest with all these health problems quite early. And again, there were some studies to suggest that some of these patients can go on to develop quite bad chronic kidney disease. And there was a small study which suggested that even some of these women are at risk of having cancer in the future. That wasn't a big study. That was quite a small study. So next slide, please. So the tips, so if you have been diagnosed with gestational diabetes, there's tips to stay healthy during pregnancy. The first thing is diet, so good nutrition. So if, like I mentioned before, if you were diagnosed with gestational diabetes, then your hospital or whoever's looking after you would refer you to a dietitian. And the thing about gestational diabetes and diet is that we want the mothers to have good nutrition, but then there's also the issue of portion control. However, it's not at the expense of each other. So we don't want a woman to say she's having good nutrition, but she's going hungry all the time. So it's trying to balance having good nutrition, but also having good portions so that the mother isn't going hungry because she's having to feed herself and both her baby. And if you got referred to a dietitian, you would be looking to have foods that have a low glycemic index. So these are foods that don't increase your blood glucose readings too quickly after you've had a meal. We always advise women who've had gestational diabetes to stay active. So this is within reason, because we don't want you trying to run for the Olympics, but it's just to make sure that you stay active throughout your pregnancy. And if you have been given a blood glucose meter, make sure you stay on track with your glucose readings. Don't just ignore it, because sometimes people get a little bit overwhelmed with having this temporary, some people call it temporary burden, and they get a little bit overwhelmed. But the main thing is to make sure that you stay on track with your glucose readings. If you are offered an appointment, please attend your appointments, because they're very important, because sometimes in between appointments, they might identify a problem and it can be resolved if you attend. And I always say, if a lot of the hospital providers, if you've been diagnosed with gestational diabetes, you'll have a lot of contact with the diabetes specialist nurses over the phone. So please make sure that you stay in contact with with your healthcare providers. Next slide, please. So after you've had your baby, so women who've been diagnosed with gestational diabetes, after you've had your baby, like I mentioned before, all the medication during pregnancy that you would prescribe during pregnancy is usually stopped. We usually encourage women to breastfeed for two reasons. Breastfeeding actually reduces the risk long-term of progressing to full-blown diabetes later. And then also breastfeeding is quite good. I'm sure you're aware the breastfeeding has its health benefits to the baby in terms of nutrition and the baby's immune system. And also breastfeeding helps to keep the mother slim. After you've had your baby, you will be invited by your GP to have a fasting glucose test. And this is a very, very important test, because this is to make sure that the diabetes has definitely gone away. Because there are some women who have gestational diabetes. They've delivered the baby, but actually there were already a risk of having type 2 diabetes. So even after they've had the baby, the diabetes hasn't quite gone away. So if you do get an appointment from your GP to have a fasting glucose test, this is 6 weeks after you've had your baby, please attend, because that's a very important appointment. And then afterwards, the NICE guidelines have changed now. So previously, after you had your 6-week glucose test, that was it, you stopped. But actually things have changed now. So what they recommend is that 6 weeks after you've had your baby and you've had your test, every year you should have a HbA1c test. And a HbA1c is essentially an average glucose, is a long-range glucose test that measures your glucose over 3 months. It's a simple blood test. But you just attend to, you just have the blood. It's a simple blood test which you attend, and then they'll measure your HbA1c, and they can tell whether your blood glucose is within the normal range if you have pre-diabetes, or if you're heading towards full-blown diabetes. So it's very important. What I always say to the women in my clinic is to ensure that if, for instance, if you've had your baby's birthday, just think sugar and attend. So use your baby's birthday every year to, as a reminder that you have to have this glucose test every year. And what we always try to encourage ladies is to ensure they don't get lost to follow up. And if you want to have a future pregnancy or want to have another baby, please plan your pregnancy. So go to your doctors, go to your practice nurses, and so that you can have a health check or a health MOT to make sure that, number one, you haven't developed diabetes, and number two, that everything else is okay. And after you've had your baby, we always advise that all the lifestyle changes which happened whilst you were pregnant, they need to continue. So if you were dieting and you were eating healthy, that's important that that continues. So that shouldn't stop. If you started exercising whilst you were pregnant, it's important to maintain a healthy weight, because after you've had your baby, if you gain a lot of weight before or after the pregnancy, that increases your risk of having type 2 diabetes in the future. So it's very important that you have regular, you carry out regular physical exercise. Next slide, please. So I'm going to go to the second part of my talk now. So I've talked about gestational diabetes, how we diagnose it and what it means, what the risks are to the mother. So the mother's a risk of going to full-blown type 2 diabetes in the future. The mother's also a risk of other serious health conditions such as heart disease, kidney disease, high cholesterol, high blood pressure. And I also talked about the HAPO study, which was a landmark study which looked at these women with gestational diabetes, and they looked at the risk of the mother's health and also the risk to the offspring. So this is the second part of my talk now. So I'm going to talk about what the risks are to women, what the risks are to children whose mothers have gestational diabetes. Next slide, please. So During pregnancy, in a woman who has gestational diabetes, there's a very high risk that the baby could grow very big. In medical terms, we call that macrosomia. And what tends to happen is, as I mentioned before, women, if you've been diagnosed, you would have serial growth scans at 28 weeks, at 32 weeks, at 34, 36 weeks. And what happens is that sometimes we find that the baby is growing too quickly. And what this means is that the baby's weight is likely to be a lot more than the average compared to a woman who doesn't have gestational diabetes. And as I mentioned before, we look at the certain things which we look at. Specifically, we look at the size of the baby's stomach. So they look at the size of the baby's head, the length of the baby's legs, but also the baby's stomach as well. So if we find that the baby's stomach is growing too big, then usually that indicates that if the woman has been diagnosed with gestational diabetes, that her diabetes isn't well controlled, and we need to do something about it. And there's been lots of experimental studies which have been done, and they found that actually, because if a woman's glucose readings are high during pregnancy, it's eventually the baby's glucose readings will be high if you are able to measure a baby's glucose readings in the womb. And what happens is the baby starts producing a lot of insulin. And one of the theories is that because the baby's glucose readings are high, the baby produces a lot of insulin. And if you think about it, you have a pancreas that's still developing. And the risk is that this could lead to sudden infant death. And there are some studies there are some theories to suggest that this is one of the reasons why women with either type 2 diabetes or gestational diabetes have an increased risk of having sudden infant death. So it's very important. So these are quite serious complications that can happen. Also, babies whose mothers have gestational diabetes have an increased risk of congenital malformations. Essentially, what they can have is problems with either heart, the heart, certain organs haven't developed properly. We tend to see that more in women with gestational diabetes and type 2 diabetes. If the baby grows very big, sometimes trying to deliver the baby becomes very difficult. And if the baby is being delivered naturally, the baby's shoulder can get stuck. That increases the risk of the obstetricians having to use instruments to deliver the baby. And that sometimes could lead to complications. After the baby has been born, because the mum's glucose readings were high during pregnancy, if someone's been put in what I call a sugar shop or a sweet shop, and then you take the person out of the sweet shop, the glucose readings are going to drop. So sometimes we find that women who've had gestational diabetes, when the babies are born, the blood glucose readings drop because the placenta, they're no longer connected to the mother through the placenta. And all of a sudden the blood glucose drop once they're delivered. Sometimes this can increase the risk of the baby being admitted to the neonatal ICU. And sometimes some of these babies can have problems with their breathing when they're born. Next slide, please. So in terms of the long-term risk to the baby, there's been lots of studies, and we found that children who were born to these women have a lot of long-term health risk. And the question is, why does this happen? It's a combination of a lot of things. So social problems, so social factors, genetic factors, and environmental factors. So if we, when a baby is in the womb, the chances of the baby coming out healthy very much depends on if the mother is healthy as well. So there's a concept of genetic programming or epigenetics, where if, for instance, the mum's glucose readings are high, the baby has a developing pancreas or developing organs. And what happens, because the baby's been exposed to a high glucose environment, they have a lot of metabolic, so the way they handle their metabolism changes. And this is even before they're born. And this could have long-term effects on the baby. So as I mentioned before, the baby starts producing too much insulin already, even before they're born. And that's mainly because of the mum's glucose readings. And the baby start to develop some, insulin resistance as well. And then there's other factors which can affect the baby's risk. So you think about the social factors, so family nutrition. So women, if you look at the studies, women who had gestational diabetes were also overweight. And that's because of their nutrition wasn't very good in some cases. And if a baby is in that environment and the baby starts to grow as a child, if they don't make changes to the nutrition, or they're having high calorie foods within the family, then that increases the risk of the baby having long-term health complications in the future. And also there's certain things which we can't do anything about, so genetics. So if there's a long-standing history of diabetes in the family, then there's very little we can do about the genetics, because that baby is already at risk. Next slide, please. So what we found when they looked at these studies, they followed up these children who were born to women with gestational diabetes. And what they found actually was that these children actually at the age of 7 were overweight compared to mothers who had a normal glucose. So these children, children of mothers who have gestational diabetes are more likely to be overweight, and they're more likely to or overweight or have obesity. Also, they did a sugar test on these children, and they found that they did have insulin resistance, and they also found that they couldn't handle their glucose properly. So there's already showing some signs that something isn't right. They measured the children's blood pressure, and the blood pressures were higher than than other children. And they started developing this thing called metabolic syndrome, where they have a high blood pressure, they can't handle glucose very well, and the skin fold thickness, so that's the amount of fat underneath the skin, was increased, and they had a large waist circumference. And what happened, so essentially they found that these children were at risk of all of these. And if you put all of these put all these factors together, this increases the risk of type 2. So if you put 2 and 2 together, all of these are the perfect recipe for developing type 2 diabetes in the future. Next slide, please. So youth onset type 2 diabetes. So I'm sure most of you are aware that type 2 diabetes is a disease that we commonly know to happen later on in life. But what's happening now is we're starting to see young children develop type 2 diabetes at a very early age. And the incidence is increasing. It's becoming an increasing problem worldwide. And pediatricians are starting to see more of these children with type 2 diabetes. And I think that the youngest type 2 diabetic patient that's a child on record is a three-year-old in Houston, Texas. So it is a big problem, and it's something which we definitely need to do something about. So trying to link this to women who have gestational diabetes, trying to link this to previous, women who've had gestational diabetes, their children are 6 times more likely to have diabetes in the future. And again, it's the same factors which increases their risk. So insulin resistance, if the child is overweight or obese, if they're eating, if they're having what we call overnutrition, so they're eating fast foods, fizzy drinks, confectionaries, this increases their risk. If they're not physically active, a sedentary lifestyle, I know there's a lot of social media, there's a lot of television that children watch these days. And so if they're not active in sport, that increases the risk of having type 2 diabetes in the future. As I mentioned before, family nutrition, family history also factors. And what they found is that actually these children, if you follow them up into the second, third decade, they start to have problems like heart disease, kidney problems quite early on, compared to people who don't have compared to people whose mothers didn't have diabetes. So obviously this is quite a serious problem. Next slide, please. So what are the symptoms in type 2 diabetes for children? A lot of the times, the children don't have any symptoms. However, if you notice that your child has unexplained weight gain or unexplained weight loss, then it's worth checking. If you notice that your child is drinking a lot and urinating a lot or peeing a lot, then it's worth checking. Also, if you notice that if your child, for instance, hurt themselves at school, but the wound isn't healing quickly, then you would need to, then it's worth checking for, to see if the child has type 2 diabetes. Itchy skin, sometimes they might have thrush, they might complain of blurred vision, they might complain of tingling and numbness in their hands, and sometimes unexplained abdominal pain. So if your child keeps having abdominal pain, it's worth going to the GP to check to make sure, especially if you have a background history in your family of diabetes. Next slide, please. So the tips to stay healthy in terms of children is early balanced nutrition. So if you have gestational diabetes as a mum, you have to be intentional about your children's diet. If you ask, there's a lot of resources these days. We have a lot of nutritionists, a lot of dietitians who can give you advice. So if you're not sure where to start, the main thing, the best thing is to seek advice. but I think the main thing is to start early. So start your children early on the healthy eating plan. I know that children, a lot of the time, they have a propensity towards sugar, and but it's important to get them to see the benefits of eating fruit and vegetables. And if you train them that way, then it makes it easier, because they start to make good choices in terms of food choices later on. So try and avoid any drinks that have or any drinks or food that have a high sugar content or high saturated fat content. So I know there's a public health campaign in England where the government now is trying to reduce the amount of adverts that advertise fast foods. And also there's also public health campaigns within schools to get children to eating healthy. And this is ensure that they're eating more fruit and more vegetables, and also making sure that they're staying active. So make sure they participate in the PE classes, or they go to community, go for walks in the park, they go play football, but just make sure that your children are active and they remain active, and try and limit the amount of time they spend in front of the television or watching social media. If you notice that your child is gaining weight, then please seek the advice of your GP or health practitioner. If you notice that your child is gaining weight too, or putting on too much weight, don't leave it. Because some people say, oh, the child will outgrow the weight, because that's something which we commonly say, they'll grow out of it, But actually, it's important to seek help early. Ensure that your children attend the health visits and the checkups, the regular checkups. I've put vitamin D there. So it's always, I've mentioned about increasing physical exercise, but outdoor exercise is very important, because not only the children stay healthy and exercise their hearts, but then also they're getting vitamin D as well. So physical exercise, but actually physical exercise outdoors is very important. Next slide, please. So just to summarize for those of you who didn't join us right at the start, we've talked about gestational diabetes, and this is one of the most common problems and one of the most common medical disorders in pregnancy, and the incidence is increasing worldwide. And from what we've discussed today, there's an increased risk of health problems to both the mother and the baby, not just immediately, but many years after, many decades later. There's also increased, so there's also increased risk of having, long-term complications, especially if there's a family history. There's also increased risks of having long-term complications later on in life. And if you think about it from a public health point of view, there's a metabolic time bomb, because if we think about, women who have gestational diabetes, they're increased risk of having type 2 diabetes. Their children are increased risk of having type 2 diabetes, and it keeps going on and on and on. So where do we, what can we do to stop this trajectory? And the message I'd like to leave for mothers who've had gestational diabetes, or if you have a family, is to be intentional about the future generation. So make sure you start your children on a healthy eating plan. Next slide, please. If you don't have diabetes, or you don't have gestational diabetes, I always encourage people to know their risk. So on Diabetes UK, there's a risk score calculation tool, which you can go on and calculate your risk of diabetes. And if your risk is high or your risk is moderate, then you know what to do. You can always seek advice from a GP so that they can help you, help you with planning to stay healthy. If you have diabetes, make sure you know your numbers. So don't stay on track. Monitor your blood glucose, because sometimes I know that having diabetes or any form of diabetes can be quite overwhelming, but make sure you know your numbers and don't ignore it. And if you find that there's a problem, please take action. Next slide, please. So this is some resources. There's lots of resources about diabetes, gestational diabetes, or any type of diabetes online. There's Diabetes UK, there's the NICE guidelines for the clinicians. And then I've put this book called Carbs and Cows. I'm sure the dietitians who've spoken previously have also promoted this book. So this book is quite a good book, because it tells you about the calories in certain foods that are quite unique to ethnic populations. Okay, so I think we've come to the end of the talk.
Thank you. Thank you, Dr. Shonibare, for that excellent talk with lots of useful information in there for us.
Thank you.
I know that there are a few questions that have come in. You have hit on some really salient points, the fact that it's important that we consider gestational diabetes as a serious condition and not just sort of take it lightly, because it has far-reaching consequences, and it also sort of has generational sort of consequences as well. Impacts on the children immediately, but also in the long term. So we're really grateful for that educational session. Now, I think we'll zoom straight into the questions, if that's fine with you. So I know you've touched on some of the things already, but someone would like you to just briefly recap what the risk factors and complications are of gestational diabetes. So that's kind of asking for what you've said, but if there were sort of two or three things that people want to take home in terms of risk factors and the complications, what will be the top ones that you'd want to hone on in?
So the risk factors for gestational diabetes, the first one is if there's a family history of diabetes in the future, and so a first degree relative. And then a second risk factor is ethnic, so depending on your ethnic background. So if you're Black or Asian, your risk of having gestational diabetes is much higher than the general population. And the third thing is the age as well. So if if someone's age is over the age of 35 and they're having a baby, then the risk of having gestational diabetes increases.
Thank you for that. So as she said, there's so many, but those are things that we can remember. At least one thing you can remember is if you're on this session, you probably are at a slightly higher risk, and if you're a lady as well, because of your ethnicity, basically. So what percentage would metformin typically lower people's blood sugar levels by? So someone wants to know, is there any sort of percentage that metformin can lower our blood sugars by?
Well, it depends on how high the blood glucose was to start off with. So metformin is effective in patients who have a glucose. So for instance, if we imagine that the glucose is 5 to 8 and the normal glucose is 5 to 8, anyone who's on metformin, we would expect that as long as it doesn't go beyond 11 or 12, then metformin hopefully will reduce it if you take it regularly. Percentage is difficult to say, but we'd expect that metformin will have an effect. However, if you find that your glucose readings are in double figures, so 12, 13, 14, metformin alone isn't going to be able to manage your glucose. And, that's when we start thinking about other therapies such as insulin.
And so people could potentially be on more things then, is that right?
Absolutely, yes. But if we look at type 2 diabetes, there's a lot of drugs that are available which we can use. But in pregnancy, we're only restricted to metformin and insulin, because all the other drugs which we normally use in type 2 diabetes aren't safe for pregnancy. So if you are pregnant, there's only metformin and insulin, and those are the two options that we have in pregnancy.
What if someone finds themselves in a situation where they don't want to have the insulin and the metformin is not enough? Do we have any other options there?
Well, no, apart from diet and trying to stay physically active. Unfortunately, there aren't any other options, because the other drugs for for diabetes aren't safe in pregnancy. The risk of that is that if your sugars aren't very well controlled, then you can have the complications that we mentioned. So having a big baby, the mother can have increased risk of preeclampsia, high blood pressure, and also sudden infant death, especially if the blood glucose isn't well controlled. So that the risks are quite they're quite serious.
Yes, indeed. And now with the COVID pandemic and all that, are we finding any link between COVID and the developing diabetes, even in children as well? Is there any such link?
Oh, yes. So I think COVID has increased the risk of type 1 diabetes. And because COVID is a virus, so what we found in the pandemic is there was lots of people who were presenting with type 1 diabetes. So type 1 diabetes is an autoimmune condition where your pancreas isn't able to produce insulin, or essentially your pancreas just completely shuts down. So we found that there was more children and adults presenting with type 1 diabetes. With regards to type 2 diabetes, I think that's just because of most people were at home, gained a lot of weight in the COVID. So that increased the risk of having type 2 diabetes. So in that way, in a roundabout way, COVID has increased the risk, increased the numbers of people who have type 2 diabetes.
Okay. And that's reflecting obviously both for adults and children.
And children, absolutely.
And
yeah.
children.
Yeah.
Okay,
Yeah.
thank you. Right. So when a lady has gestational diabetes, you've mentioned that one of the potential complications could be having a big baby, which obviously then can lead to complications during delivery. Is it possible for women who have gestational diabetes to still have a normal birth? And what would be the sort of birth method recommended? So can they still have normal births?
Yes, they can. I'm not an obstetrician, but yes, they can still have normal births. So we've had women who've had gestational diabetes who've been a great success. So we've managed to get their blood glucose under control early. And they've had, it's been a relatively normal, normal pregnancy with no other complications. So yes, you can have a normal delivery. The only thing is that if it's not well controlled, there is that risk of the baby being too big. And because it's too big, then they have to have a cesarean.
And when you say too big, what kind of range are we looking at roughly? What size baby would we class as too big?
Well, so I think the guidelines say 4.5 kilos. So at the time of, at the expected date of delivery, 4.5 kilos. But I think it also depends on mum size as well. So if you've got quite a petite mum, it's also relative to the mum side as well. So if you've got a petite mum, then she might not be able to carry a 4.5 kilo baby, and a 3 kilo baby might be big for her. So I think it's relative to mum size as well.
Okay. So back to her point, it's important that we do whatever we can to prevent getting it in the first place. But if you do have gestational diabetes, then do comply with all the management and the treatment, especially so that hopefully you can have a normal delivery and a normal sort of size baby. There is another question about, is the monitoring mandatory during pregnancy for gestational diabetes? So I suppose that the person would like to know whether the glucose tolerance test, the follow-up test, the serial scans, are those mandatory?
I think, when we practice medicine, it's all about patient choice. We recommend, so I'll be very careful. So we recommend that if you've been diagnosed with gestational diabetes, that you should monitor your blood glucose, and you should attend your follow-up appointments, especially the growth scan appointments, to see if the baby is growing too big. Sometimes they notice complications happening in between. So we definitely recommend that you do follow, you do attend these follow-up appointments, but as a patient, you have a choice not to attend. If you have a reason that you don't want to, no one will force you to, but we certainly recommend that that you go to your follow-up appointments and monitor your glucose.
Do you find that some people are not keen on follow-up, and is there any particular reason why? Because I find that sometimes people DNA, or they don't attend their follow-ups, or even their postpartum follow-ups, they don't come for it. Is there anything that you have identified as a potential reason why people may not be keen for follow-up or engaging with the monitoring that's required?
I think during pregnancy, in terms of the follow-up, one of the reasons why is sometimes if the mum has lots of young children, so we find that, for instance, that we've got a very busy mum who's looking after many children, sometimes it's difficult for her to attend because, to be fair, if you have gestational diabetes, you will see a lot of the clinicians in the hospital. It's a lot of appointments to attend, and sometimes it gets in the way of life. Sometimes we meet women who are in complete denial, so they just, they don't think of it as serious enough. And then after they've had the pregnancy, they don't attend the follow-up appointments. And I think mainly it's about education. And that's what we're trying to do, to educate people that actually gestational diabetes is quite serious, not just for the short term, but for the long term, not for mum, but also for baby as well. So it is quite serious. So that's why education is important.
Thank you. Thanks for that. So please, let's try and engage with follow-up. And if you are having any challenges, discuss that with your clinician. Let whoever is looking after you or the team around you know what challenges you're facing, because as Dr. Shonibare said, this is a very serious condition and it has far-reaching consequences. Right. So can prediabetes be identified by a non-fasting blood test? So not necessarily a fasting, but is there a non-fasting blood test? Presumably for someone who may not be able to fast or doesn't want to fast. Is there another way around it?
So a HbA, so I'm presuming this is outside pregnancy.
Yes. They haven't specified, but they've just said.
So pre-diabetes is so outside pregnancy. Yes, you can use a HbA1c. So the HbA1c is the lab glucose test, which you don't have to fast for. You just go to You just go to your healthcare provider and have a blood test, and that will tell you whether you have pre-diabetes or not. In pregnancy, in pregnancy, once a woman becomes pregnant, the HbA1c naturally falls because she's having to compensate for both her and her baby. So it's difficult to diagnose pre-diabetes in pregnancy. However, if you look at some of the studies, they reckon that gestational diabetes is a form of pre-diabetes, actually. So, although it's not officially recognized, but in hindsight, some people reckon that it's a form of pre-diabetes.
Yes. Okay. And are you seeing, obviously we've talked about the fact about ethnicity playing a part, race and things like that. Do you think that poor compliance could be one of the reasons why we are seeing higher numbers in our ethnic groups? Do you think that could be contributing to the rise in the numbers of diabetics or gestational diabetes patients? Because probably we're not complying as much, or we're not engaging as much. Is that a possibility?
Yes, I think compliance is one issue, but I think education and awareness is another issue, because if people are made aware of how serious something is, then I think they'd engage a bit more. So yes, compliance is definitely an issue, both from the medical point of view and also diet, from the diet point of view as well. So being intentional about our diets and physical activity.
Thank you. And again, thanks for your time as well, because sessions like these educate us, they tell us what we need to know, and we're hearing from the specialists themselves. And on that same thread, we do have a healthy heart session on Tuesday, where there will be a dietitian talking about diet-related changes that can be made in relation to gestational diabetes. So you can certainly tune into that as well. Now there's a few more questions. I'll just pull these out of the chat box. Can anxiety, depression, stress, can that lead to gestational diabetes?
Yes, long term, because anxiety, stress, depression increases your cortisol. Cortisol is a steroid hormone that we all produce, but it also affects the action of insulin, and it can raise your glucose. So long-term significant stress, persistent stress, can increase your risk of gestational diabetes. But usually there's another risk factor as well in the background.
Okay. So if we can minimize the stress, if we can seek help for that, that would also make a difference as well.
Yeah.
Right. So there's a comment here. It's quite worrying, the risk of gestational diabetes among the Blacks. So someone is saying that he's got parents who have type 2 diabetes, and I think it's a she, I beg your pardon, and she's also thinking of becoming pregnant as well. So obviously that, the risk factors are sort of building up with the family history, and she being overweight as well. What advice would you give to try and avoid? So I guess it's going back to what you've said, but specifically, what advice would you give to someone who's got these risk factors, who are also overweight, who are thinking of becoming pregnant?
So I think the best time to manage your risk is even before you get pregnant, and I think that's a perfect question. So if you're from a Black background, your risk is, you've got risk 1, and then the second risk is both parents. So those are compounding risk factors. So the first thing is to lose weight. So when you look at the HAPO study, one thing that I didn't mention it earlier on, the thing they did find is that if the mother lost weight after pregnancy, then they tended to improve. Then they tended to reduce or mitigate the risk of health problems. So weight is very important in reducing your risk of having gestational diabetes. Even if you have gestational diabetes, but your weight, you manage your weight before pregnancy and during the pregnancy, you don't gain too much weight, you find that the severity of the gestational diabetes isn't that bad. So the main thing is weight control through diet and exercise.
Okay, right. So I hope that helps to the lady who's asked that question specifically, and to anyone else who has identified that they have several risk factors as well. Are there any specific exercises that are safe or not safe during pregnancy? Is there anything that we need to avoid, or are we okay to do anything that we class as being healthy during pregnancy?
Like I said, I wouldn't encourage anyone to start running like Usain Bolt or trying to run, train for the Olympics, walking. So I always advise women to go for a brisk walk. The other thing in pregnancy is towards the end of pregnancy, women have this thing where the hips become loose because the body's getting ready to deliver the baby. So what happens is they have a lot of pain in their hips. So I would say go for a walk as within reason. So what you can, cope with. You can do lightweight exercise, so dumbbells 1 to 2 kilos. Or if you're watching television, just walking on the spot or a light run on the spot, but nothing too strenuous. A bit of light Zumba. So these are just, things that women have told me that they do at home, light Zumba, light dancing, but nothing too strenuous because you don't want to then put stress on your body because you are carrying a pregnancy.
Right. And equally, is there any specific, I know you're not a pediatrician, so this is probably a bit unfair on you, but any other advice for the children as well? So children whose parents have diabetes or had gestational diabetes, or generally nowadays we're seeing a lot of overweight children, as you said in your talk. What are some of the things that we can do to help? I know you've mentioned it already, but if you can kindly repeat that for us, please.
Okay, so I'd recommend physical exercise, especially outdoor exercise, because the children are getting the exercise. So any form of exercise, playing ball, participating, enroll your children in physical exercise in school. Go walking to the park, organizing community activity days. So any form of outdoor exercise. So I wouldn't necessarily, it's difficult to prescribe a certain type of exercise for children, but that's any form of exercise where they're running and they're keeping their hearts active. But also avoiding fast foods. Like I said, children have a propensity towards, McDonald's. And even if you were giving your children McDonald's, let it be a treat. So once every 3 weeks, rather than making it a daily habit. But then also exposing your children to eating healthy. So the concept of eating healthy, if you start that early, then you'll find that actually they themselves, when they become adults, they make those right choices with food. So children tend to pattern their parents in what they eat.
Absolutely. Thanks for that. Thank you. That's a very important point. I guess kids would want to have their way, wouldn't they, if we allow them to? So we need to guide them and we need to help them make the right choices. So there's a comment. I think this is more of a comment or contribution, but I'd like your sort of take on that. So someone said, we do have a continuous model of care targeted at risk groups. And this model of care helps improve pregnancy outcomes. So this is a follow-on from the lady who'd posted a question about having several risk factors, what can be done. I mean, are there specific models of care that would target people who are specifically in that risk group? Something like this is obviously one of those where we've got the Caribbean and the African health, the community coming together to talk about this. Are there other things that are going on that we need to be aware of in relation to diabetes, please?
I think it depends on the region. So what we call the CCG, so the areas in which they provide healthcare to populations. As far as if your class is having a high risk of diabetes, there are some programs such as Walking Away or the Desmond. These days, they're expanding it to even more people who are high risk of developing diabetes. But again, these vary from region to region. What I always recommend is that if you have identified yourself as having a high risk, visit your GP and your GP or your practice nurse, and they'll be able to point you to what's available in your area. Also, there's a lot of online resources. You'd be surprised how much you would find. Actually, there's really, really good talks on the CAHN as well, because on the CAHN website, on the CAHN website about the healthy hearts, I think it happens during the week. And actually, there's a wealth of information from there as well. So there's many places where you can, but the models of care depends on the region. So some regions are very organized and have got that in place because they've got high risk populations, but other places is not as advanced.
Yes, thank you. So do find out what's going in your area or speak to your GP practice and find out what's going, or you can send an email to CAHN and we can share any information that we've got with you. The email is health@cahn.org.uk. Thank you for that, Dr. Shonibare. So one of our callers on the forum, who's actually a psychiatrist, has also said psychology in pregnancy is also important when it comes to dealing with stress in pregnant women and people obviously suffering with anxiety and depression. So he said, get some help. if you're experiencing those things, speak to somebody. Your antenatal care is a very important part of your overall care, but also get some mental health care if you are struggling with that as well. So thanks for that from the colleague who's put that in. Right. Okay, so is there a link between gestational diabetes and neurodevelopmental presentation of children such as autism? So is there a known link?
So I deliberately left that out. So there was a paper which was published, and they did suggest that there was a neurocognitive developmental problems in women who have gestational diabetes. It was a small study, but then there have been other linked studies to suggest that not necessarily autism, but they have found that when they measured certain things in terms of the child's intelligence quotient and other, there's other things which they measured that sometimes they were lower in women with gestational diabetes. But I was quite careful to avoid that because, it's not a big study. So it's something that has to be really, represented in all populations for us to take that as the gospel truth. But yes, there are some suggestions that there might be neurocognitive problems in children, in some of the children.
Okay, right. So there are lots of comments in there saying a very informative session, very educational. Thanks for your time. We've benefited a lot. So just to feed that back to you, Dr. Shonibare, it's been an excellent presentation for us as well. I've learned a lot. It's interesting because as clinicians, we never know it all, and it's nice to hear someone else present, and you always learn something as you go along. Just going through the list to make sure that we haven't left anything out. So we're just wrapping up the Q&A session here. If you haven't posted your question in relation to the topic, please do so now or forever hold your peace. Subsequent questions can be sent to health@cahn.org.uk. Right, so Dr. Shonibare, any last words from you, please? Any take-home messages, anything you'd like the opportunity to sort of hammer before we leave this place? Thank you.
Okay, so I think my take-home message is gestational diabetes, although it's a temporary diabetes, is quite serious. So there's short-term, long-term consequences for both mother and baby. If you don't have gestational diabetes, or, for everyone on this platform, please know your risk about developing diabetes or any other form of diabetes. So know your risk, go onto the DUK website and check. And then if you do have diabetes, know your numbers. Please keep on track, keep on top of your numbers. And also, if whatever your risk is, take action, be healthy, stay active, eat well.
Thank you so much. And I would want to say we're really grateful for you're taking your time out on a busy Saturday to come and educate us on gestational diabetes and diabetes in children, the risk factors, all the things that we need to know. And I'm believing and hoping that we're going to take action. We do have Healthy Heart session on Tuesday, and it will specifically be related to dietitians' inputs with gestational diabetes. So please do tune into that. And there are a number of other programs as well, which the team will let us know in a minute. If there are any private questions that were sent to me, which are not linked to this, I will respond to you. So please don't feel that you have been ignored. And once again, thank you so much, Dr. Tolulope Shonibare. It's been an absolute pleasure having you, and we've really benefited a lot. Thank you so much.
Thank you. Thank you.
Thanks for everyone for bearing my hosting as well. I hand over to the team. Thank you.
Thank you so much, Dr. Tolu Shonibare and Dr. Diana, for the fantastic hosting as well. Thank you, Dr. Tolu. Yeah, fantastic. It's one topic that's really close to my heart. So yes, I will just share a few events that we're going to have in the coming weeks. My colleague will share the slides in a minute, please. Thank you. So can you share the slides, please? Thank you. So next week, we'll have, as mentioned, we have gestational diabetes for our Healthy Heart session. So that is coming up on Tuesday. So please tune in on Tuesday and listen to our dietitians talk about gestational diabetes and how you can manage it with your diet as well. And just as Dr. Tolu mentioned, it relates to your weight and then control, diet, and exercise. So these are the things you hear about on Tuesday. So please join us. Thank you. Next, please. Next slide. And next week, Dr. Shonibare is back again for another session on diabetes, eye, and food care management. So please join us next week for that topic. Thank you. And then today we've got our Africa Day. So if you're about in Manchester, please join us to enjoy and celebrate Africa Day today. Everyone is welcome and the family can join as well. Thank you. And then we've got our Windrush event on the 25th of June at Alexandra Park. That's our flagship event. So join us for a fun day. If you've got any ideas, please email us and please register as well. And then next slide, we'll be talking about stalls. So if you've got anything to display, do contact us and you can get a stall through us as well. Thank you. And then we've got our gambling awareness workshop coming up on the 6th of June. So yes, please share this with your contacts as well. And anyone who is interested in this, join us for this session. And last but not the least is our services. We've got our services, counseling services, family advocacy, and our domestic and sexual violence helpline. Please join us, tune in, and also ask questions next week. Thank you very much for joining us today. We appreciate your time and hope to see you next time. Thank you, Dr. Shonibare. Thank you, Dr. Diana. Thank you to everyone who's joined from different parts of the UK. We are really grateful. Thank you very much and see you next time. Thank you.
Thank you. Bye.
Bye.
Okay.
Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.